Um, I'm going to say just a few words in Spanish, Dr. Ommen, and then we're going to follow up with your introduction and whatnot. Buenas tardes a todos, es un gusto tenerlos. Hoy voy a moderar esta sesión con el doctor Juan Pablo Maña. Juan Pablo está en este momento en cirugía, pero esperamos que salga pronto para que se ure en un momento. Mi nombre es Héctor Medina, trabajo en la Fundación Cardioinfantil en el área de imágenes cardiovasculares. Les recordamos que al conectarse a esta conferencia autorizan el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la ley 1581 del 2012 y nuestra política de datos personales, la cual puede consultar en www.cardioinfantil.org. De igual forma, les informamos que esta conferencia está siendo grabada. El chat de preguntas se encuentra habilitado en la barra de participantes y les agradecemos dejar allí sus inquietudes, las cuales resolveremos al final de la sesión. Today, we have the honor to have with us a very, very special speaker, which is Dr. Steve Ommen, talking about an update in the diagnosis and management of hypertrophic cardiomyopathy. Dr. Ommen got his degree of biomedical engineer at Northwestern University in Illinois, and this was followed by medical school at Mayo Clinic, College of Medicine, and also by internal medicine residency and cardiology fellowship, also at Mayo Clinic. Dr. Ommen is the medical director of the Mayo Hypertrophic Cardiomyopathy Clinic, which is the largest and longest continual single-center clinic specializing in hypertrophic cardiomyopathy and has extensive experience in this condition over the last 25 years. He has been honored with awards for clinical care, individual excellence, team excellence, and recently was named one of the top 15 digital health executives in the US. His numerous contributions to the field are unparalleled, and we feel extremely proud and lucky to have him as our speaker today, talking about his favorite disease, which is hypertrophic cardiomyopathy. Dr. Ommen, welcome. The podium is yours, and it's an honor and a privilege to have you amongst us.
Hola, buenas tardes. It's my honor to be able to speak to you today, and I'm glad to talk about hypertrophic cardiomyopathy. As I put my slides up here, I'll just comment that I have no disclosures for this talk or any other that I give. And hopefully we'll have some time for some questions and answers. It's always good to start these talks with kind of a case in mind as we talk about it. And while I won't ask you to raise your hands on Zoom, this is a 36-year-old woman who has some shortness of breath, really noticing over the past 6 months. It's worse after she eats meals. It's worse when it's warm and humid outside. On her physical examination, her carotid upstroke is brisk, her lungs are clear. She has this murmur, 2/6 systolic ejection murmur that kind of peaks late, and it increases when we had her do squat to stand maneuvers in the office. So she was sent for echocardiography, and she has left ventricular hypertrophy with a very thick heart, but there was no systolic anterior motion of the mitral valve or obvious outflow tract obstruction. And so the question here is, what's the next best step for this person? Should we get a CMR? Does she need echo with provoking maneuvers? Should we send her to the cath lab, or does she need a TEE? And we'll come back and we'll answer that here in a second as we go over these issues. So every patient that comes into our hypertrophic cardiomyopathy clinic needs to learn these things about HCM. First of all, while it's not the most common disease we see, it's also not that rare. But anywhere between 1 in 200 to 1 in 500 people has hypertrophic cardiomyopathy around the world. Doesn't really seem to be any ethnic or geographic hotspots or cold spots. Overall, the prognosis is good. Most people with hypertrophic cardiomyopathy live a normal number of years and die from something else. And that's important because patients will look up on the internet and find all these dramatic stories about transplants and early deaths and all those kind of things. And while those things can happen, the majority of people, the ones who aren't writing stories on the internet, do really well. As you know, this can be a genetic condition. When it is genetic, it typically is inherited in an autosomal dominant fashion, meaning each child of an affected patient has a 50-50 chance of inheriting this. So we recommend screening for family members. We can use genetic testing in some cases, or we use surveillance echocardiography on a periodic basis every 5 years in adults and every 1 to 2 years in children. We'll talk later on in this discussion about sudden cardiac death and the role for the implantable defibrillator. We'll spend a lot of time coming up next on the treatment of symptoms and kind of wrap up at the end with exercise and healthy lifestyle considerations. So when we talk about treating patients with hypertrophic cardiomyopathy, or any disease for that matter, there are really four main goals we're trying to do. Ideally, we'd have something that was curative. Well, we don't have that in hypertrophic cardiomyopathy. We have nothing that cures HCM. We don't even really have anything that prevents disease progression that we know of. There's nothing that changes the natural history. All of our medical and surgical therapies are symptom relief is their primary goal, and the ICD can save lives. And those are the two big bubbles on this screen that we need to focus on in terms of our treatment for patients with HCM. So when we talk about symptoms and the therapies we're going to use, we need to understand why patients get symptomatic from their HCM. Now, one of the things that isn't talked about a lot is that the blood flow at the capillary network is not as dense in a patient with HCM as it is in a normal thickness heart. So they live closer to subendocardial ischemia than someone who has a normal thickness heart. The other two big things are on this screen. Nearly everyone with HCM has some degree of diastolic dysfunction. The thick heart muscle is inherently stiffer than the normal thickness heart muscle. It takes more pressure to fill it. Relaxation is often slowed because of the thick heart muscle and also because of some of the abnormalities that happen at the cellular level in terms of actin and myosin. But then obviously for years now, we've been focusing on this systolic phenomenon of systolic anterior motion of the mitral valve and left ventricular outflow tract obstruction. And so that left ventricular outflow tract obstruction increases the pressure within the left ventricle, which means the coronary perfusion pressure is further decreased. So these patients get more ischemia when they try to exert themselves, and that worsens that diastolic dysfunction. The systolic anterior motion of the mitral valve inhibits normal function of the mitral valve and causes mitral regurgitation, which causes further abnormalities of left atrial pressure and pulmonary wedge pressure. And then obviously the obstruction can cause some decreased stroke volume issues as well. But that obstruction is very dynamic and very manipulable, which is why we spend so much time working on it and identifying it for patients. So this is, again, a representation. Most of you are going to be familiar with this. This is the anatomy that causes left ventricular outflow tract obstruction. You can see that because of that basal septal hypertrophy, the blood flow, when it's leaving the heart, actually has to go across the mitral valve and pushes that anterior leaflet into the outflow tract, as opposed to the normal circumstance where that blood flow is parallel to the mitral valve and it can close normally. We consider patients who can generate a gradient of at least 30 millimeters of mercury to have obstructive physiology. But importantly, we think it takes a gradient of at least 40 to 50 millimeters of mercury, a peak gradient of 40 to 50 millimeters of mercury, to be responsible for class 3 symptoms. And that's important because if you have a patient who is really short of breath and you only get a gradient of 35, either you need to find another cause for their shortness of breath, or you need to prove that their gradient can get higher than that. Now, and that's kind of, if I go back to this, that's kind of the purpose of that original question I asked you. There was a woman who was short of breath. On physical examination, she had a murmur, but the resting echo didn't show anything. So we needed to do more. Was her shortness of breath due to non-cardiac causes, or should she have had provocative maneuvers in the echo lab? That's what she should have, is some sort of provocation to see if she can generate a gradient of 40 to 50, which would then serve as a target for our therapies. Now, you all know the pathophysiology, that this dynamic outflow tract obstruction gets worse in states of increased contractility, decreased afterload, and decreased preload. And those are the things that we can manipulate through medications, hydration, et cetera. So that's been the target of therapy. Those are also the things that happen as soon as a patient stands up and walks across the room. As you know, when a patient is getting an echocardiogram, they're in a horizontal position. It maximizes their preload. They're at rest. Their heart is not in such a high contractile state. So when the resting gradient you get in the echo lab is probably the lowest that patient's gradient is going to be throughout the day. It's higher as soon as they leave the echo lab facility. So this is this woman. I just kind of gave you the answer to this. We did do squat to stand maneuvers with her in the echo lab, and it showed with that maneuver that she generated a gradient of 64 millimeters of mercury at peak. So now we know that she does have very severe, with effort, outflow tract obstruction. And so now we can target that for our initial therapies. So the mainstays of therapy are to use beta blockers or the non-dihydropyridine class calcium channel blockers, specifically verapamil and diltiazem. All of those agents decrease contractility, and they slow the heart rate down, which gives more time for diastolic filling and further maximizes beat-to-beat preload. We'll talk more about disopyramide coming up, but again, that's also a negative inotrope and negative chronotrope that has some of the same properties. Importantly, getting patients off of medications that may be hindering their progress is important. A lot of patients, particularly if they're middle-aged or older, might have concomitant hypertension, and they might be put on an ACE inhibitor or something like amlodipine or nifedipine for their blood pressure. Well, those vasodilators are decreasing their afterload and making them much more likely to develop outflow tract obstruction and therefore symptoms. And then obviously we counsel all of our patients with obstruction on making sure they drink plenty of hydrating beverages throughout the day. Now, this is an important slide because success in medical therapy is not guided by the echo lab. Identifying that they have obstructive physiology is clearly a key thing that we rely on from echocardiography. But once you've determined the patient has obstructive physiology, then you listen to the patient and how they're doing. So if I start a medication on a patient and they feel better because of that, that is success. The echo gradient changes every few minutes. So you may catch them on a good day one time and a bad day another time, but holistically, the patient's gradient may be lower from day to day and they're doing better. So that's why you have to really ask the patient how you're doing. And this graphic represents a very biased, referral biased population. All of these patients were sent to us because they were deemed failures at medical therapy, but yet you can see that we sent away 2/3 with simple medication adjustments and successfully treated them that way. So it's important that we get people on the right medications, off of the wrong medications, and titrate the medications effectively. So this is a version of the schematic from the American College of Cardiology, American Heart Association guidelines that we published in 2020 for the management of obstructive hypertrophic cardiomyopathy. And right now we're really on the left-hand side of this slide. So it's important that we treat patients with HCM for their comorbidities, and you treat them aggressively. Their hyperlipidemia, their hypertension, their diabetes, their sleep apnea, you treat all of those things. And if a patient is asymptomatic, they are not required to go on medical therapy. So you don't have to just automatically prescribe beta blockers to these patients if they're active and asymptomatic. But if they do have symptoms, as I said previously, get them off of vasodilators, get them off of high-dose diuretics, and get them onto beta blockers or one of those 2 calcium channel blockers. And then if they become asymptomatic, then all you do is reevaluate them every 1 to 2 years. If they get more symptoms, then they'll move on to the advanced therapies on the right-hand side that we'll talk about coming up. So this is going back to our patient. She had her gradient. We tried her on metoprolol. Then she had bad side effects to that. She got really sleepy and tired, the typical beta blocker side effects that so many patients complain of. So we tried her on diltiazem. It helped a little bit, but she started to get the lower extremity, edema that some patients get, and it really didn't, get her to doing the types of things that she wanted to be able to do in her life, activity-wise. So she really is not successfully treated at this point. So this again is where we move over to this right-hand side where we talk about advanced therapies. And that's where you start to tell patients that they have options of going on more advanced drugs or moving to septal reduction therapy. And it's important that to communicate that we don't force all of our patients who have failed first-line therapy to then have a trial of disopyramide. Some patients can go right to myectomy or septal ablation once we've had a thorough discussion of the pros and cons of each of these. So as you know, disopyramide is a 2 to 3 times a day medication. It has some anticholinergic side effects that are intolerable for some patients, but some patients aren't emotionally ready for making a decision for something invasive, or they're so frail you might not want to send them there. So it can be a good option. You usually use it in combination with one of the first-line therapies to serve as an AV nodal blocking agent. But then there's this new drug that's come on the scheme this year called mavacamten, and was approved by our Food and Drug Administration in April as the first ever drug from the cardiac myosin inhibitor standpoint approved specifically for the treatment of HCM. So what is the issue with this? Well, at the cellular level in patients with HCM, actin and myosin they have too many cross bridges. It's actually too strong of a bond between the actin and myosin. So they're actually hypercontractile and using more energy. And the fact that there's so many actin and myosin head units hanging on each other, that's part of why they don't relax as well. And so this new class of drugs, mavacamten is the first one, aficamten is also out there, actually loosen up those connections and get more of those actin and myosin into rest state. And that is a potential mechanism of action to help our patients feel better. So there have been a number of trials of this. There was the preclinical trial in Pioneer in obstructive HCM patients. It showed decrease in LVOT gradients, improved exercise capacity, but there was some issues with left ventricular ejection fraction falling because it's such a potent negative inotrope. The Maverick HCM study was a phase 2 trial in non-obstructive patients, seeing if it would help with the relaxation. We really aren't going to spend too much time talking about that today, but it did show some benefit in terms of surrogate markers for outcomes. And then Explorer HCM was the trial upon which the FDA approved this agent, a phase 3 trial, randomized controlled trial, 251 patients. Almost all of the subvariables were pointed in the right direction, and we'll go into more detail on that study. Valor HCM was another study looking at patients who were eligible for myectomy or ablation and chose to be randomized to mavacamten as an alternative. You can see that this, in terms of resting gradient, patients who were treated with mavacamten had a nice reduction in their left ventricular outflow tract gradient, and even with Valsalva was improved as well. So what did this trial show? Well, first of all, it was a 30-week trial. So think about that. That's less than a year. And we might be considering putting patients on it that might need a drug for multiple years, et cetera. There was a pre-specified endpoint that was not too rigorous. It was an increase in VO2 of 1.5, which is about the same as you get when you advise one of your sedentary patients to start an exercise program. You can increase that by 1.5. And an improvement in New York Heart Association class. And you can see that 37% of mavacamten patients did that as compared to 17% in placebo. So effectively, that's a net gain of 20%. You can see a mean decrease in left ventricular outflow tract gradients of 36 millimeters of mercury, but 10 patients did have a drop in their EF to less than 50%. Now, fortunately, that's reversible. You stop the drug, the EF comes back up. At least all the patients that they've seen so far in the trials, it's been a transient drop, and once you get them off the drug, that gets better. When I look at the totality of the mavacamten trials, this is what I communicate to patients who are considering this. About a third of the patients get a lot better. It's a myectomy-like result for these patients. They feel tremendous. About another 30% feel somewhat better, but 30% of patients don't really get much change at all. And then there's that 10% who have the drop in ejection fraction. The main side effect that patients complained about with mavacamten is some dizziness. It didn't result in cessation of the drug in a lot of patients, but it was reported by a number of patients. How does mavacamten, well, and this drop in ejection fraction then resulted in this complicated scheme by which, if we're going to use it in the US, we have to enroll patients in this risk evaluation and management strategy. That means they have to get monthly echoes for the first 3 months they're on the drug and every 3 months thereafter. They have to check in with us every month to get their prescription refilled. There's no giving them 3-month or 6-month prescription. It has to be renewed every month to make sure they aren't on any medications, because mavacamten is both an inducer and inhibitor of the CYP metabolic pathway. So there are many drugs that it might interact with. You have to make sure that it can't happen. And the FDA has told us how we will adjust the dose based on the patient's symptoms and echocardiographic obtained gradients. So it really is a pretty rigorous program. The other thing is the drug is obviously a new drug, so it's expensive. If the patients have good healthcare insurance, it's quite affordable for them. If they had to pay full price for the agent, it's about $250 per pill, a once-a-day pill. So it can be too expensive if patients don't have good drug coverage from their health plan. If you look at mavacamten compared to disopyramide, it wasn't a randomized controlled trial, but this is an observational multi-center study of patients on disopyramide, and there 2/3 of patients didn't have to escalate their care to something more aggressive for the 3-year period of that observational study. It had a similar hemodynamic benefit, and about 7% of patients had drug intolerance to disopyramide. When patients come to us, in fact, I had a patient who said to me the other day, after I talked to them about all these medications and the pros and cons, he said, "Doctor, I really have to mess around with these medications, or can I just get surgery?" And the answer to that is yes. And so let's review the indications and outcomes of septal reduction therapy. So for both of the procedures, the baseline indications are the same. They must have LV outflow tract obstruction that is causing symptoms that is refractory to the pharmacologic therapy, beta blockers and calcium channel blockers. In our studies done here at Mayo Clinic, having a myectomy normalizes long-term survival as compared to their age-matched peers. And here you can see that in our all-comer patients on the left-hand side, that whether they have myectomy or ablation, the survival free from recurrent symptoms is very good out to 4 years. For the younger patients, and we think this is probably because they're more active, myectomy, which does a better hemodynamic job of relieving the symptoms, outperforms ablation in those patients. You can kind of come up with a scorecard of the things that patients are interested about. The hemodynamic response is slightly more robust with myectomy. The need for permanent pacemaker is slightly better with myectomy. Mortality rates are roughly the same. Obviously, length of stay is going to be shorter with an ablation. Pain is going to be better with ablation. Return to activities is going to be quicker with ablation because you don't have a big sternotomy. They both have been proven to improve symptoms. We quote about a 90 to 95% success rate with myectomy and about an 85% success rate with septal ablation. The rates for reintervention are very low with a properly performed myectomy. Long-term sudden cardiac death appears to be reduced with myectomy, perhaps with ablation, and long-term survival is obviously very good with both of these things. So some patients recognize that they have a mechanical problem, this mechanical obstruction to outflow in their left ventricle, and a mechanical solution is sometimes the best option. Particularly true if they have a very thick heart or a very high gradient. Sometimes having to go to this kind of mechanical solution is going to be the best bet for those patients. Experience matters for this. So this is from an article in 2016, and Nish and I wrote an editorial with it showing that there is a difference in how outcomes compared to how much experience places have. So the the left 3 columns were from a national discharge database where they just did tertile. So the lowest tertile volume patients, 1 in 6 died having a myectomy. The middle tertile, 1 in 10 died. The high volume, 1 in 26 died. But if you pool data from Mayo Clinic, Cleveland Clinic, Tufts, the New York University, collectively, we had more than 1,000 patients without a death over a large period of time. So the point was, we don't think every hospital in the US needs to have a myectomy program. You're better off sending your patients to surgeons who do this all the time than you are trying to stand up a program. The same is true, not quite as dramatic with septal ablation, but experience matters there as well. Now, if we look at the hemodynamic results of all these therapies we've talked about in terms of how many patients still had a resting gradient of 30 millimeters of mercury or more after initiating that therapy, you can see there's a difference here. Beta blockers don't do much for the resting gradient. They probably do suppress the exercise-induced gradient. Similarly, disopyramide does slightly better, so many patients can feel better on that. Mavacamten in the Explorer trial still left 43% of the patients with an operable gradient. Ablation, again, about 25% of patients after a single ablation will still have a gradient. Sometimes a second ablation gets that lower down to the myectomy range. So there is a difference in what to expect and counsel your patients regarding outcomes of these different therapies. So now when we look at this, I think the myosin inhibitors fit over here in this advanced therapies option. So when I sit with patients and they have failed the middle of this screen, I tell them their options are disopyramide, mavacamten, myectomy, or ablation, and talk to them about the pros and cons of each of those in detail. There are some things, if they choose septal reduction therapy, that makes myectomy more favorable. If you need to do something else structural to the heart, or if you're going to add an intraoperative pulmonary vein isolation for their paroxysmal atrial fibrillation, myectomy is going to be much better. Myectomy is also going to be better in a younger patient, the patients who have the thickest hearts and gradients of more than 80. Myectomy is more likely to give you a successful outcome than ablation or than medications will. So once we've gone through this algorithm of helping patients feel better, we can't forget that we have to talk to them about this issue. This is the paper that's recognized as heralding in the modern era of management of HCM. What's notable about this, published in 1958, is this is an autopsy series. So the first modern publication about HCM suggested that HCM was highly fatal by the age of 50. Well, as I mentioned in that first slide in this talk, we now know that the sudden cardiac death rate is actually about 0.8% per year, not this nearly 100% that we see here. And so how do we help patients understand their risk for sudden cardiac death and whether or not they would benefit from an ICD? Well, prior to 2010, the way the world went about that was counting up risk factors they had. And you know what the risk factors are. It's family history of sudden cardiac death, a scary sounding faint, a super thick heart, non-sustained ventricular tachycardia, all those types of things. And if a patient had 2 or more of those risk factors, they usually got a defibrillator. If they had 0, they didn't. And then there was this global debate on whether a single risk factor was sufficient to recommend an ICD for patients. And it was fun to go to all the national meetings, international meetings, and hear the debates about this, but it really didn't move us very far forward. When we wrote the 2011 guidelines, we decided to dig into this and look at which variables had the highest level of evidence. And that family history of sudden cardiac death in a first-degree relative, super thick hearts, and scary sounding fainting episodes had sufficient evidence that we said any one of those 3 in isolation was sufficient to give a class 2A recommendation for an ICD. Non-sustained ventricular tachycardia and blood pressure response to exercise didn't quite have so robust of a agreement. They probably needed something else to get you to the class 2A. You could maybe put in an ICD with class 2B. But so we felt like this was a data-driven advancement of that. And we included that box in the middle here that said, these are things that aren't quite risk factors, but you really can't ignore. We thought that was a good way to kind of split the difference, and it worked pretty well. We've seen publications that this is a highly sensitive screening tool for identifying patients who are at increased risk for SCD. When the European guidelines came out a few years later, they included this tool, the HCM SCD risk calculator. Now, I really like this tool as an educational thing because it helps us communicate to our patients, yes, you have increased risk and your risk is actually this much. In the example I've got here for this patient, he actually has no risk factors. His risk for cardiac arrest in the next 5 years is 2.3%. That's very useful when you're talking to patients, just like we talked to them about risk for TAVR procedures or valve replacement operations. We give them those percentages because it helps them figure out how big their risk is. The problem, in my opinion, with this European recommendation is they actually used predetermined cutoff values to say who was eligible and who was not eligible. So if you had an ICD, a 5-year risk of 6%, you were more than likely going to get an ICD recommendation. Well, you know, each individual patient has different levels of risk tolerance. Some people hear that 6% risk as a 94% chance nothing's going to happen in the next 5 years, and I'm good with that. And so we didn't like the idea of a priori clinical decisions based on a number that didn't include the patient's part of that discussion. And that's how we evolved the discussion coming into the 2020 guidelines. This is just an example of 5 patients with different levels of risk that we looked at. In the first column with the risk factor, that would be the number of risk factors they have. So in 2010, 2 of the patients would have been debatable depending on whether you lived in Europe or America. The second 2 patients would have gotten an ICD recommendation from everyone, and the third patient wouldn't have. Based on the 2011 guidelines, those first 4 patients all had a class 2A indication, which meant you have a discussion with the patient about whether or not they wanted an ICD. And then if you use the ESCD risk criteria, you can see that 2 of the patients would have gotten a strong recommendation and 2 of them would not. So we tried to take both of those things and blend them together, the high sensitivity screening tool and the risk calculator as an education, communication, decision aid for patients, but not a decision maker for patients. So this is the figure from the 2020 guidelines. It's the same top level risk factors with the addition of LV apical aneurysm, so thinned and scarred. Plenty of evidence now that is a strong risk factor for sudden cardiac death, as well as a low ejection fraction, now are sufficient to result in a class 2A indication. The asterisk here is when we say we use the risk calculator to talk to the patient. Non-sustained ventricular tachycardia means more in children than it does adults, so we dichotomize that there. And then we also added extensive, meaning more than 15 to 20% of the LV, gadolinium enhancement on MRI as a potential class 2B indication. So the presence of any one of those risk factors makes a patient eligible for an ICD. Eligible at different levels, class 2B or class 2A. But if you have a risk factor like that, you're higher risk than people who don't have that risk factor. And so therefore we think the patient deserves a discussion about ICD options. You use the risk calculator to communicate the magnitude of the risk to the patient, to help them understand and put it in the context of their life and their wishes. And then you make a decision together about whether or not to proceed. We have reconfigured that HCM SCD risk score into these tools, which are available on the AHA website or on these 2 apps, which are available in the App Store, the AHA guidelines and the ACC guidelines. You can enter the information. It does give you the 5-year risk, but the recommendation for an ICD implant is based on the risk factors, not on the number that the calculator spits out, but it's there for conversation purposes. And we think this is a really nice way to go about communicating with patients and making that decision on something that's quite important for them. Now, last, we're going to switch to this discussion. You're all familiar with this history that when a study was done of athletes who had died, HCM is overrepresented. This showed that athletes with HCM are higher risk than athletes without HCM, and that resulted in this dogmatic approach to excluding patients with HCM from athletic competition, and unfortunately also had many cardiologists advising patients not even to exercise. But this is in part a misinterpretation of this data. Again, this study of dead athletes shows you that it's higher risk to be an athlete with HCM than it is to be an athlete who does not have HCM. It does not tell you if you're a patient with HCM, is it higher risk if you're athletic or non-athletic? It tells you the first side of the story. It's higher risk to be a cardiologist with HCM than a cardiologist without HCM. It doesn't tell me if I have HCM, is it higher risk to be a cardiologist or not? And so to determine whether patients are truly at high risk for that, we would need to do a study on this, on the second pairing, athletes with HCM versus non-athletes with HCM. There are now plenty of emerging data to suggest that the usual exercise recommendations that we give to all of our patients result in the same positive health and wellness benefits for HCM patients as patients without HCM. Less diabetes, less metabolic syndrome, less hypertension. All those things get better if you have patients exercise at the low to moderate intensity activity levels. When we've done studies of patients who remained athletics when they've had an ICD in place, we aren't seeing excess ICD discharges in those patients. But there is one study that suggests perhaps there may be some incremental risk to being an athlete with HCM compared to a non-athlete with HCM. And that is, if you project out the prevalence of HCM in elite athletes times the sudden cardiac death rate amongst patients with HCM, you would predict that in the United States that we would observe 3 sudden cardiac deaths due to HCM annually. And in one study that looked at it, they saw 4. And so statistically, it would take a giant study to prove whether 3 was different than 4, but we also can't say definitively that that's not different because the N is so small. So when we talk to patients now, I don't dogmatically disqualify them from high-level exercise or even competition. We have a discussion about the fact that they may be at increased risk. There's no way for us to quantify that risk. But if they think it's important to them to continue those activities, that is their right to do that. Now, that doesn't mean that a given team has to take them. Just like your local football club might not take someone who's had a knee injury before, their team doctors, their team coaches may not want someone who's had a hurt knee before. Same thing here, the team doctors, team coaches, or team lawyers may not want someone who has a diagnosed heart disease to be on their team. But that doesn't mean the individual can't pursue that with a different team or a different club. But it's a careful evaluation, a careful conversation with someone who's comfortable with this conversation, and it really should be repeated annually with all the appropriate testing that we do. We certainly do counsel our patients to participate in light to moderate exercise as part of a healthy lifestyle. So as I wrap up my comments here, and we'll have some time for discussion, hopefully, remember that our patients need to learn that the overall prognosis for HCM is completely compatible with normal longevity and a good quality of life, that we want to make sure that their family members get screened so that they aren't missed, that there is a small but real rate of sudden cardiac death, and some of those patients are eligible for ICDs. All the rest of our medical and surgical therapies are designed to relieve symptoms, and that we want people to be healthy. So thank you very much for inviting me to talk to you today, and I look forward to your comments and questions.
Thank you, Dr. Ommen, for your extremely illustrative talk. I wanted to introduce you to the head of our cardiac surgery program, Dr. Juan Pablo Maña, and he also likes quite a bit the disease, and he's the one has been taking a lot of the myectomies here. Juan Pablo, there he is. There you go. Hi, Juan. This is Dr. Ommen.
Steve, how are you? Thank
Good,
you. Thank you for agreeing to be here today. This was a great talk. I apologize for being late. I was actually in the OR, but was happy enough to be able to make it 10 minutes into your talk. But this was fantastic.
Thank you.
Several questions. While we get questions from the rest of the participants, there's I got the impression that you, if not enthusiastic, you seem to like ablation, and I'd like you to expand a little bit more on that, because my feeling, and that comes from your teachings in Heart, Soul, Shafts, of course, is that if you have a competitive team, if you have a multidisciplinary team to take care of these patients, you really should proceed with myectomy, and in the great majority of cases. You want to comment on that, maybe?
No, I completely agree with you. So I would say our ratios of myectomy to ablation are 5 to 10 to 1. So most of our patients who have drug refractory symptoms end up with an extended myectomy, unless they're frail unless they have mild gradients and they're not ready to commit to an operation, or they have complicated other diseases, that doing an ablation becomes more appropriate. But I completely agree with you. I have the distinct pleasure of getting to work with Hartzell and with Joe Deraney, who are so good at this operation that it's easy for me to refer them to know that they're going to get that kind of great outcome. So I agree with you.
No, I don't want to be the only one asking questions, but let me ask you something else. The second thing that I found very interesting and very important is patient participation and in the decision making process. And you expanded a little bit more during your talk on of course the decision to implant an ICD, and I think that has always been one of my pet peeves. I think that you can't just tell a patient that he needs an ICD. I know that if I ever need an ICD, I would be the one making that decision. I think that the degree of post-traumatic stress disorders that we miss in patients with ICDs is tremendous. But in terms of what I find with these patients are two things. One, patients who come from the community, cardiologist, the common cardiologist doesn't really know how to take care of these patients, and oftentimes they're under medicated, not appropriately medicated, and as a consequence, you need a proper clinic taking care of them in order to be able to really discriminate which group of patients will get better with medication, which ones, as you said, are too frail for surgery, and which ones should go to surgery. How do you manage the referral process and clinical treatment of those patients?
Yeah, it's a really great point. So I think it was about 1996 when Jamil Tajik decided that he didn't want the HCM patients coming to Mayo Clinic to be seen by anyone. He wanted to have a small group of individuals who were focused on it. And so that really launched the era of the subspecialty clinic at Mayo Clinic, and HCM was one of the first. And so we continue to have about 5 of us that work in the HCM clinic. We have about 150 to 200 cardiologists at Mayo. So there's only 5 of us that really, all of those patients, the referral center, the appointment coordinators know that if the HCM is their diagnosis, it needs to go to this clinical area to be seen. We have our test algorithms all set up and those types of things. So the bigger issue is identifying the fellows who might be interested in bringing them on to succeed someone else who might be moving on, et cetera. But we definitely have our system set up so that it's one of the 5 of us that is seeing the patients. If someone is referring from outside and they know one of us, that's fine. If they don't know somebody, then we give them the first available appointment. There are some patients that are automatically referred to Hartzell because someone knows Hartzell and says, gosh, this patient needs surgery. But if Hartzell gets that consult, he will send them through our clinic first so that they get all of the non-surgical discussion about family screening and ICDs and all those kind of things handled. And then he'll do the surgical consultation and decision making and operation after we've handled the rest of the patient holistically.
Thank you much, Dr. Ommen. I have a question coming from the chat and also a personal one. I do cardiac MR, and the cardiac MR data has been quite controversial. There was this very, very interesting paper by Tevik Ismail from the Brompton saying there was no evidence that LG would be helpful, and that kind of rocked the boat. But then the meta-analysis published by the Chinese group said that there's an 80% risk of increased mortality. And I know that the Brits are working on getting a 5,000 cohort, and I think you also are involved in that cohort. What are your thoughts on it, and what's the clinical decision-making role of CMR? You mentioned in one of your slides, if there's extensive CMR, the patient should get an ICD. What are your thoughts on that?
Yeah, it is a very controversial thing. There are some people that advocate that every patient with HCM should get a CMR, and others who don't think that. I mean, obviously, if the echo images are suboptimal. The CMRs are going to give you better spatial resolution. You can see maximum wall thickness. You can get some idea of obstruction, those types of things. But the data around sudden cardiac death risk, as you can see in the algorithm, we said if you have extensive LGE, it was a class 2B indication for an ICD. And the way I phrase that to patients is, you're eligible, but it's the way we interpret the data is it's not mandatory you get an ICD. It's really, if you're anxious because you hear about this and you want an ICD, then we have the ability to put it in and not have any reimbursement or coverage problems and those types of things. I do think that LGE represents the electrical substrate, though, for ventricular arrhythmias. And so if you have LGE and non-sustained VT, that's 1 + 1. And to me, that almost makes it a 2A with that combination of things. So we get CMRs, particularly if a patient hasn't already decided on their ICD pathway, someone who's clearly going to get an ICD, or someone who says, I will never get an ICD. They probably don't need the CMR because it's not going to change any of your clinical decision-making. If they go through and their brother had a cardiac arrest at age 40 and they're already so freaked out that they're going to get an ICD, again, you don't need to do it. But if you still aren't sure, or they're not sure, getting that can help the patient understand that whether they have substrate for these rhythms that might be fatal. I see that there's a question in the chat I can see about how do you quantify LGE. We could have a whole nother hour session on that. And in fact, our radiologists at Mayo Clinic don't like to give us a number because of the debate on the methodologies on assessing LGE. And clinically, I kind of feel the same way. I think we get hung up on numbers and the precision of numbers, when really what you need to know clinically is there a little bit, moderate amount, or a lot? And it's the a lot that makes me nervous. And I can't draw, it's a gray zone, but clinically, that's the way we all practice for everything. Is someone having a lot of symptoms or mild symptoms? Are they having a lot of LGE or not much LGE? And make that decision rather than getting too hung up on the numbers. The 30 millimeter cutoff for maximum wall thickness. Well, you all know that 29 millimeters and 31 millimeters are not clinically different no matter what method you're using to measure that. So we really shouldn't have a hard dichotomous line in the sand to make decisions. So I try to preach being a doctor who looks at the whole picture with your patient, helping them make decisions on that's a really thick heart and that looks like a lot of scar.
Thank you so much.
No.
Juan, do you have another question?
I do. How do you follow the patients? How do you follow these patients post-operatively after myectomy? What's your algorithm to follow?
Yeah. So our algorithm is when patients get dismissed from the hospital, we set up an appointment with them with their primary care provider within 2 weeks, mostly to look at the wound, because primary care providers know what wounds are supposed to look like in infection. We set up with their referring cardiologist within a month. And if the patient is doing well and recovering well, we don't have them come back to Mayo Clinic. If there are postoperative complications or problems or concerns, or there isn't a local cardiology team, then we'll have them come back. But more and more, we've been doing those postoperative videos, not just in cardiology, but thoracic surgery and GI surgery by video, just to see if the patient actually needs to come back for testing, if they're actually doing okay. But we really like to get their referring physicians back into the loop and helping those patients so they don't travel so far to see us if they don't actually have to.
What about anticoagulation or antiplatelet therapy versus and beta blockers and other medications?
Yeah, so most patients go home on a beta blocker, particularly if they were on one preoperatively, because obviously you can't stop the beta blocker cold turkey when you've just invaded their body. Their adrenaline's going to be super amped up and they're going to be over responsive to that. So everyone goes home on some degree of beta blocker. Usually we always stop the disopyramide if they've been on that immediately. Calcium channel blockers kind of depends on how the patient's heart rate and blood pressure we're doing early postoperatively. But the patient that goes home on any of the agents, I usually like to talk to them 2 months after their operation either that's messaging in our portal or by a video visit. And if once they get beyond that 2-month mark, let's see if we can wean you off of those medications, because many of them don't actually need to be on those drugs anymore because the myectomy is so successful. Anticoagulation, we don't do routinely unless they go home with, they've had a lot of post-operative AFib and, it wasn't kind of self-limiting. They might go on a DOAC and amnio for 2 months, and then we'll reassess their AFib at that point.
Great. Now, and I think I promise this just might be the last question, Hector. What about the mitral valve?
Yeah.
Because that I find that to be a big issue. Most patients, and I know from your data as well as Cleveland Clinic's, most patients mitral valve will get better with a proper myectomy. But there is literature out there of the benefit of a single central alveoli stitch,
Yep.
which we've done in the past, and ends up being almost prophylactic if you do an extensive enough myectomy, and I'm not sure there's a benefit to it. And then there's the question of mitral valve replacement when you actually need to replace the mitral valve. I find it very concerning to use a bioprosthesis as the angle tends to lead to earlier structural valve deterioration.
Yeah, completely agree. So again, I have a very biased opinion with the experience that Joe and Hartzell and before them Gordon Danielson in terms of their myectomy success rate. And I think that they probably do a more extensive myectomy than most surgeons do, which opens up the outflow tract, and then the mitral valve typically behaves normally. In our experience, it's something like 4% of our myectomy patients need a mitral valve intervention. And of that 4%, 96% of those are a mitral valve repair technique of some kind. And only 4% of 4% ended up needing a replacement to fix primary mitral valve pathology that they discovered in the OR. Now, Doug Swistel at NYU doesn't do as extensive as myectomy, but he likes to do a plication stitch in the mitral valve to make it a little bit stiffer so it's not so wobbly getting in the outflow tract. That's a little bit, the craftsmanship of being a surgeon is knowing what you're comfortable with and how you can come up with different solutions for what's going on there. It is our belief that if we can leave the mitral valve alone, that's probably better for the patient in the long term. But again, these are surgeons who are doing 150 to 200 of these every year and are very comfortable with the exposure they need to do this really long and extended myectomy. I agree with you about if you do have to replace a mitral valve, you have to be really careful what you put in there because the ventricle is still thick beyond where a myectomy would be. And if you put in something that's got this big strut structure, it's either going to get bent or it's going to impede flow by itself, et cetera. So I think that's a difficult thing. So we really try to avoid mitral valve interventions if at all possible.
Perfect. And I think there's I don't think there's another question in the chat. Is there a role for 3D impression or 3D printing pre-op?
We haven't done a lot of that to date, but I think that is probably going to be, we're going to see more and more of that. And part of even for training, I mean, as those of you who do the procedure know, it's a tough thing to teach someone because there's only one person who can see what's going on. It's not like you can kind of stand back and say, see here, feel here. It's a really kind of narrow field of view. And so having some sort of 3D assessment ahead of time to help surgical planning and teach the next era of surgeons to do this operation, I think is going to be a key benefit to keeping the success of myectomy where it's been.
Got a question about phenocopies, Dr. Ommen. We had a case recently that was kind of totally groundbreaking for us because we had someone who we thought he would have had HOCM. We're not doing T1 mapping at the time, and it turned out to be a Fabry disease. How often or what's your genetic panel or phenocopy checklist that you do when you get one of these new consultations on your Holcomb clinic? And how can you guys make sure that you don't get one licked away and then you find something that is totally treatable, like Fabry's?
Very good question. So all of our patients that come in get alpha-galactosidase testing, and they get monoclonal protein studies looking for amyloid or those types of things. Obviously, the CMR is also going to give us some look at that as well if they don't null properly during the late gadolinium imaging. So that's the way we try to screen them that way. The other thing that we just recently had a patient that the echo lab called me, someone else called me and said, I don't think this person has HCM. I think they've got amyloid. You should get PYP scanning and cancel their surgery. Well, the person had a resting gradient of over 100. So regardless of the underlying pathology, that patient had a hemodynamic problem that needed to be fixed. And by doing that, we were going to get this giant biopsy. And so if the hemodynamics are so bad, it's not bad that they end up in the OR. If it's a borderline case that you're sending them to the OR where they've got a minimal resting gradient and the walls are mildly thick and maybe they've got Fabry's and with protein with replacement therapy, those walls might get thinner. Well, that one you might want to avoid. But most of the patients we see, we've had a handful that come back post-operatively with amyloid, had one with Fabry's as well, but they had severe hemodynamic problems that needed to be fixed anyway. So it wasn't like I felt we went in the wrong direction with those patients.
Sounds good. Sounds good. We're about to close, but I just remember that Juan Pablo bullies me very frequently because I love publications of yours about where there's sigmoid septum.
Yeah.
In addition to the lower back pain and the, carpal tunnel syndrome, those patients you should read a red flag. And you can imagine the amount of bully that I got from Juan Pablo. It's like an elderly brother type of bully. But do you, every time you have one of those patients, with the publications you did, I think it's a decade ago, you were part of the publication, you usually are peeling that off of that septum when you see it's really sigmoid, or that's something anecdotal and we should not be as worried as
it's more anecdotal. I mean, again, there are people that debate whether that really sigmoid septum, where it's just that one basal segment, is hypertrophied. Is that truly hypertrophic cardiomyopathy? Is that some sort of configuration change of the elderly? It's an interesting academic debate. They don't have a very high yield on genetic testing when we do it. On the other hand, they can have severe gradients that are causing them symptoms and changes in their lifestyle. We need to fix that somehow. So sometimes when it gets that level, you have a symptomatic thing you need to do, and then we can debate what the underlying pathophysiology was. But if they have that severe obstruction, but we see a lot of patients that have sigmoid septum who don't end up having alternative diagnoses or phenocopies. So it's not like even though we have such a strong amyloid clinic here at Mayo, it's not like most of those end up being amyloid.
Okay, sounds good. Happy to continue to be bullied by Juan.
Thank you very much. That validates my bullying, man.
Okay. Juan, do you want to wrap up with Dr. Ommen?
Yeah, well, again, I just want to thank you for the opportunity to speak to you. And if you have questions afterwards, don't hesitate to reach out or send me an email, and I'll try to answer those for you. But it was my pleasure to talk to you today, and hopefully we can meet someday live and in person.
Hopefully we'll be able to have you here soon. It was a real pleasure, Stephen, and it'd be great if we could put together a state-of-the-art, including the entire team, to have a bilateral multidisciplinary discussion in the future. Thank you so much for your generosity with your knowledge and for a wonderful lunchtime talk.
All right. Thank you. Have a great afternoon.
A pleasure and a privilege. Have a good afternoon, everyone. Gracias, Juan Pablo. Gracias a todos los participantes. Que tengan una feliz tarde. Bye, guys. Hasta luego.